So we're joined today by Rose Dewey. Rose is the Research Management Lead for West Yorkshire Research and Development at the West Yorkshire Integrated Care Board. And Rose is presenting today the Practicalities of Research with NHS Data. So I'm going to pass over to Rose, and there'll be opportunities for questions at the end. Or if you do have any questions, please feel free to put them in the chat while the presentation's going. And then at the end of the presentation, I'll help Rose funnel those questions. And just another reminder for everyone, please, if you could put yourself on mute while Rose is doing her presentation, that would be fantastic. And I'll pass over to Rose. So over to you, Rose. Thank you.
Thank you. So as Kate says, I work in the West Yorkshire Research and West Yorkshire Integrated Care Board. So my role as part of the research team is helping research studies to get into practice. So working with practices and working with researchers to hopefully smooth over the process of getting research studies started. So I started the presentation calling it NHS Data Gold Mine or Minefield. So I start off by, oh, hang on, it's now decided it's not going to work. There we go. So the government published a white paper in 2022 boldly called Data Saves Lives, talking about better use of data in the NHS. One of the parts of that was about research data. And there's links to all of this in the presentations, which will be shared afterwards. So as well as the government strategy Data Saves Lives, there's been a big review done by Dr. Ben Goldacre called Better, Broader, Safer, which is about the use of health data for research and analysis. So that's, again, it's a real focus and a push from on high that we will use data more effectively and more in the NHS or with the NHS. So often people talk about the data held by the NHS as a gold mine, which I'll talk a bit more afterwards, but understanding and accessing this data is not as easy as it could be. So the minefield that I mentioned. So I'll start off by looking at the NHS landscape. So as you'll probably know, the NHS as one thing doesn't work in that way. It operates as a series of separate individual organisations. So this is the integrated care system of West Yorkshire. So since, again, 2022, the integrated care systems were brought in, and that's only in England. There's actually a different set of systems, different systems in Scotland, Wales and Northern Ireland. But across England, we have 42 ICSs, which are individually set up, and they will, so everywhere else in England will work differently, but similar to this. And this is just basically a way of bringing together all the organisations that can impact on the health and care of the population. So as well as the NHS trusts, which are the acute trusts and community mental health trusts, on the right-hand side, there's other organisations which have impact. So there's the local councils, which provide a lot of the social care, the organisations like the police and fire services, the NHS England and Health Education England, NHS Digital, which is part of NHS England now. And nationally, there's also the UK Health Security Agency, which used to be Public Health England, local organisations like Health Watch, and the National Institute for Health and Care Research, all bringing part of the picture. On the left-hand side, you can also see that there's a list of lots and lots of other organisations which form part of this system, which are, if you try to show all of these on the map, it would just be massively complex and hard to read for a start. So these numbers that are provided on the bottom left are from November 2022. So they're not the numbers that will be accurate as of today. But this will just give you a guideline. So there's nearly 300 GP practices operating in West Yorkshire, over 500 pharmacies, 277 dentists, then we've got optometrists, hospices, care homes, care services delivered in people's homes, lots of other things, lots of other NHS and associated services. Some of these are not operated directly by the NHS, and many of them are operating separately and differently. So as of November 2022, there were nearly 12,000 voluntary community and social enterprise organisations in West Yorkshire. It's now more like 14,000. So there's a huge number of organisations. So I just kind of wanted to show the complexity of the picture, the landscape that we're working in. And like I said, there's 42 of these across England, as well as all the different systems in Wales, Scotland, and Northern Ireland. So bringing that back to data, how does that work? How does that inform the data landscape? So when I showed this presentation to my head of department, and he said, "Oh, it's a bit controversial to say an organisation has its own data. Who owns the data? Isn't it the patient's data?" Well, that's a debate for another day. But what I'm trying to say is that they're holding the data for their organisation all separately and independently. So each of the organisations on that previous slide has a data set which they hold. They operate a particular system. They are not all operating the same system. Not even all the NHS organisations operate the same system. In terms of GP practices, which is where I work mainly, all GP practices operate either the EMIS or System 1 systems. So they are operating a small number, they only operate one of those systems, but they are independent and they're operating separately. So even those two systems in in general practices are not the same, and they operate in different ways. Each individual organisation decides what it does itself, so it has its own way of recording data. It'll have SOPs and processes and procedures that it works slightly differently. It has its own data controller, so it is a data controller for the data held in that practice or in that NHS or other organisation, and it's responsible for its own data. It's, again, I'm not talking about ownership, but the holding of that data. And it shouldn't be overlooked that it's human beings working in these organisations that enter that data. So they're not necessarily working in a consistent way. We're all human, we're all fallible, we're not necessarily doing things exactly the same, even if we are working to processes. So again, that makes it a very, very complicated picture. And every individual living in West Yorkshire or being treated or cared for in West Yorkshire will have records in a unique combination of these organisations. So I have a hospital record, I have a GP record, a record with my dentist, I could have a record with a care home, I've got an electoral local council record, council tax record, and every individual has a unique combination. And every one of these systems has records captured by multiple people at multiple time points. So it's an ongoing system with there's lots of systems operated by lots of people dealing with lots of patients and care users over time. So it makes it a very complex picture. So when I say the gold mine, I'm not talking about making money, and I'm not talking about the NHS selling off data or anything like that. But I'm just talking about how rich that data is and how valuable it can be to support research in particular. So every patient registered with the NHS has a unique NHS number, and usually that's from the cradle to the grave. So you have the same NHS number through your whole life. Obviously, if you weren't born here and you came into the country later on, you will get an NHS number issued when you are registered for the first time, and you'll keep that NHS number. As well as that, adults might be on the electoral register. They'll have a national insurance number usually. And then there's a reference number for children as well, called a unique pupil number. So in theory, we should have access to a really, really rich data set, and we should be able to tie everything together with these consistent identifiers. So the NHS number, for example, is used across multiple organisations. We also have something called coded data, which means we've come a far cry from the handwritten notes of previously, and we have something called coding, where patients have a code recorded on their record to show a particular diagnosis or a particular treatment. And that should help to make the data consistent and searchable. So that's all good news about how good that data is. But we need to have a really good understanding of that data before we start to access it. So this is at the planning stages before you even start to apply for funding, and certainly before you ever come into contact with any data or any participants, you need to have a really good understanding of what the data you're looking at. So you need to have an understanding of what data you would like as your first part. What data do you plan to use for your project, and what could you use? So then you think about what's available, what format it is in, and is that data collected? I go into that a bit more afterwards. And so really it's a good idea to talk to the people who actually are using or are dealing with that data day to day, and then what is actually there. You might not be able to look at it, but you can ask somebody who can look at it what's there and what's available. So next point, can you get it? So is it something that you can obtain? And I'm going to go into more about how you obtain data and how you find out what you can get. But that's a big consideration. Is it usable? So we have data on there that's not usable. So either it's not in a usable format, or you can't use it for research purposes. So some data, or because the data is collected for care, direct care, there are different things that need to go on before you can use it for research purposes, and you might not be able to use it for research purposes. So you need to understand also who you need to talk to get this data. So hopefully some of this presentation will help. We can also help to signpost if you want to get in touch afterwards, or there are people holding the data or organisations that you will deal with. They'll be able to put you onto the people that you need to talk to. And it's also worth understanding the accuracy of the data. There's some data that's collected, so for example, for financial purposes, and that might be more accurate than other data. So you might be more able to vouch for the accuracy of the data if it's captured for a particular purpose. You can gain a better understanding of whether it's accurate. So I kind of put this into a bit of a Venn diagram. So there is the data that you want. That's the main thing. You start off by thinking about what data you want, and then you go to the next bit of finding out what you can get. And hopefully there's a nice overlap in the middle, which will be data that you can get and want. But there will be data that you want that you can't get. And there'll be data that you get that you have to wade through because you don't want. So hopefully there's a nice big overlap in the middle. It might be the case that the project needs to be rethought if there isn't an overlap at all, or if there isn't a big enough overlap to inform what you need for your project. So thinking about routine data. So main thing that I'm talking about here is about routine data. So when we talk about routine data, you might question what's captured. So every single interaction in the NHS and lots of these other organisations as well, every interaction with a patient, whether that's face-to-face or virtual on the phone, that's captured. Letters are captured, that's between clinicians and also from clinicians to patients. Test results, imaging, prescriptions, measurements, symptoms and diagnoses. So again, as I said, there's a really, really rich data set. There's loads of information there that's routinely captured every day for every interaction in the NHS. But the next bit, where is it captured? Well, it's captured everywhere. It's captured in those individual organisations. So it's in lots of different places, and it's held in lots of different places. But it's also really important to consider why it's captured. So the reason this data is captured is for service delivery, not for research. So it might mean that it's not captured in the way that you think makes sense, or the way that you would assume that the clinician or the service is recording data. And it can't be assumed that it will be recorded in the way that you need, and you can't change how if you change how they, or ask them to change how they record things, then it's not routine data anymore, it's different processes. So the reason that they capture data is to inform their service and potentially for informing how service is delivered. So whether they need to put more resource in a particular area or something like that. So they will record it in the way that's useful to them and their service. So like I said, not necessarily in a way that's useful for you. So do consider making sure that you understand how they capture things, because it might not be how you might assume they do. So how things are captured. We've got loads of records, and we all have these things called coded records. That means that we put a code against a patient rather than typing in a condition or a treatment. And the coding system that we're working to across the NHS now is called SNOMED. We previously used read codes, and I think before that there was something else as well. So we should have consistent codes across organisations. NHS organisations use SNOMED codes, and some other organisations will, but some organisations won't use those. So there will be some uncoded records, and there may be some with old codes still, because things update, but things can take time. And like I said before, humans and our fallible humans doing all of this recording. And when I mention codes between services, I'm sort of thinking about maybe a social care service in the council might record things differently or use a different code, and services might use codes in different ways as a standard code. There are free text elements to records as well. These are not very usable. There is some initiatives about to try and make these records more usable and able to be kind of coded or brought out or searched and sortable. But generally, it's very difficult to use free text. So if you have a plan to incorporate the free text element of records, you need to discuss that with a research team like ours, or with the holders of the data, to see if that's something that you can use or extract. Obviously, in the past, and until relatively recently, all the records were on paper, handwritten records. GP practices have been using electronic records for something like 20 years. Hospitals have come into standard electronic records a bit more recently. There is a big push to standardise and get everybody using electronic records, but it's something like 90–95% of hospital trusts are now using electronic records. So it's still not that everybody uses electronic records. So there's, and we all know that there will be reams and reams of paper held in loads of these documents, loads of these organisations, gathering dust. And there has been a big project to scan and digitise all of those paper records and put codes against them. This has been going on for quite some time, but it is a very big project. So it can't be guaranteed that it's all there, all coded and all accessible. So if you want to do anything historic, just bear that in mind. So who captures it? So we think about your GP after you've gone to see them, or maybe during your consultation, noting things down on the record, but quite a lot of codes are actually applied to the records after the fact. And that obviously applies to the scanned documents. This is done by a non-clinical member of staff. So there is a little bit of fallibility again about that. And it should be borne in mind that, yeah, there may be non-clinical people coding records, and it might be done after the fact. So it's not a perfect system, but it's a good system, I like to think. And again, that said, not all of this is accessible for research purposes. Patients can opt out of the use of their data beyond their direct care. There are some data sets that you can't access because they are provided for care. They are there for care purposes, and they consider a research purpose as a use that's not agreed under confidentiality, under all the regulations. So some of it So that's why we need to kind of have an understanding early on to see what's accessible and what can be used for our purposes. Oh, it's not changing. Here we go. So data linkage. So tying data sets together can be vital for rich research. You might be able to find something about a condition by just looking at one data set, but you might need to use multiple data sets to find out what you need, especially if you're linking together a risk factor and an outcome. So do people living in a particular area experience a particular health problem? Do patients with a particular characteristic respond in a particular way to a treatment? Do people engaging with a particular service experience better outcomes? So these are the sorts of things you might need to pull together sources from pull together data from different sources. So these, like I said, they will be held in separate places. They might be on systems that don't interact or talk to each other very well. And data linkage requires that there's an identifier attached to the patient in records in the data set 1 and data set 2. So that you can match people together, you've got to use an identifier. And that makes it pseudonymized data. So even if you start with anonymized data, attaching a pseudonym and the NHS number is a pseudonym and it can't be anonymous if you've applied a pseudonym. So there is just a few more data considerations using linked data sets. It makes it more identifiable. When we're looking at routine data, primarily we'll be looking at accessing it from the source. So as I said, those data are held separately, and you need to understand who you need to talk to find out what you need. You need to understand what's there and how you can get it and in what format. So the ideal thing is to talk to people in the organisation where you're applying to access the data and find out what there is and how you can access it. There will be an element of checking data cleansing to make sure or to improve the accuracy of what you've got. There are approvals that you need to go through, as well as a site agreement and a data sharing agreement with that site. And that will often include working with the Caldecott Guardian. So each of these sites has an individual Caldecott Guardian responsible for the data security of the data they held. So it's a really good idea to describe your data flows, use a data flow map or some sort of template to have a really good understanding of what data you're wanting to access, how it's going to flow, how it's going to interact with other data or other systems. There's a 5 safes framework, which is mainly for trusted research environments, but it's quite a good thing to work towards, which is about safe data, safe researchers, safe people, safe projects. So all the approvals that are in place, there's 5 safes in this framework. So that's another link, another information for that. We also work towards an NHS toolkit, data security and protection toolkit. So organisations wanting to work with data can use that toolkit to demonstrate that they can operate to the standards required for NHS data, so that they operate to the same level of security as we require within the NHS. So let's go to some of the approvals that are required. So obviously all research has to follow and adhere to the applicable law. So GDPR and the Data Protection Act are obviously about protecting the data that we have and we're using. The Caldecott principles are the fundamentals that we have to adhere to act safely. Always should be working within the common law duty of confidentiality, which is a really important part of the of our requirements and of our approvals. We all have always have to operate within a data protection impact assessment. So the HRA's guidance is that a DPIA is conducted at sponsor level. So that means that rather than you doing a separate DPIA for every project that you do, the HRA says, do a DPIA to cover the standards that you work towards as a sponsor. And then you only need to do a separate DPIA for a project if it goes outside of those standards. So there's a link there to the DPIA. So that's something that is always required for NHS work. So the sponsor should have a DPIA for their work. All research, even if it's just data and not having an intervention or any interaction with any patients, requires Health Research Authority approval. So it's one of the categories on the IRAS form. So it starts off with clinical trials, then qualitative research, quantitative research, blah, blah, blah. And then near the bottom, it's research just involving data. So it's still a criteria. It still counts as a research project with the HRA. You probably would need to go for Research Ethics Committee approval. If it's at all identifiable, you would usually use REC. So that's an application that goes through at the same time as the HRA. Confidentiality Advisory Group, commonly known as CAG, can set aside the common law duty of confidentiality. And that means that if you need to obtain patient data, participant identifiable data without consent, you can use a CAG approval called Section 251 to set aside the common law duty of confidentiality. So the CAG is not very easy to obtain if you have a good reason. So if there's a way that you could do it without with consent, then you will not be issued. Then CAG wouldn't normally issue approval. But CAG can be a way to, whether it's not feasible and where it's not practicable to obtain consent from the individuals involved, you can request approval from CAG. And DARS is the Data Access Request Service, which is it's a service for accessing data from NHS England. So that's another one you can go through. So all of those are linked to find out more about those. Now, there are other options if you don't choose to go down the route of accessing data through the source directly. So there's anonymized data, which you might need to get from source again, but if you can do research using anonymized data, it makes it so much easier. You don't need to consider patient consent or a lot of the confidentiality requirements. So fully anonymized data, if you can use it, then that's much more usable, much better, easier to use. HDR UK, which is Health Data Research UK, is a group working on health data, and they've created this gateway where they pull together loads of data sources, so they can be a really good way of finding a source that you can use and request data from. We've got in Bradford and in some areas of the UK, we've got Connected Cities, which is a data set where they've linked together things like hospital data and GP data, and they can create linked data, but it's anonymized at source. That's a really useful resource you can apply to. And then there are some more overarching anonymized things that you can access. So Fingertips is a public health data set. ONS, Office for National Statistics, holds a lot of data. Open Prescribing holds data about loads of the prescribing happening in England, so you can get loads of prescription information from there about who's prescribed what, when, and where. CPRD is the Clinical Practice Research Data Link. That's an MHRA tool which you can access or you can request to access. So all of these, so Fingertips, ONS, Open Prescribing, you can just go onto their website and access a lot of data from there. CPRD and the next ones are all about, are all sources you have to apply to. So NHS Digitrials and NHS England data sets you can put in a request to use data from them. SDEs are secure data environments, previously known as TREs, trusted research environments, and they're a way of a data set being held centrally, and rather than them sending out data to a researcher, they invite the researcher to come into the secure data environment and access the data there, and then only extract the results of their analysis. So that's a really good way, and that's something that's been really pushed towards. And there's going to be a national SDE as well as some local SDEs. So they can be a really good way to overcome some of the need for some of the permissions and confidentiality, because it's all handled within a secure environment and it's all accessed by approval and under the 5 Safes framework. So there's plenty of other sources, and there's local sources and local SDEs. And again, it's a case of talking to the people who hold that data and finding out where it is and can it be used. So just to go through a few of the pitfalls, sorry, I think I'm running over a little bit. Some of the things that we come across that researchers sometimes fall down on. So assumptions about what's captured. So as I said before, the records are captured for the purposes of providing care and delivery, providing care and planning care. So you can't assume that they will capture what you think they should capture. It's also definitely shouldn't be forgotten that data extraction often requires a manual intervention and work. So therefore there's a cost, because especially in GP practice, all those extra work they have to do takes away from the work that the day-to-day work that they have to deliver. So it's not a case of you having to pay for the data, but you have to pay for the person who's going to extract and coordinate that data for you. As I said, you have to deal with multiple gatekeepers, and you have to go to the individual organisations to access the data, unless you're going to use a separate organisation. You've got systems that don't talk to each other, don't work in the same way. So for example, if you want to do a search in general practice, you would have to create a search for EMIS and a different search for System 1, because they work differently in their different systems. You do need to consider the national data opt-out, and that's an ongoing thing. So if you have checked the list against the national data opt-out list, you would need to check again if you're going to continue to hold and use that data. Use of software. So some research projects try and use a piece of software that's going to do some of the extraction for them, and then the number of times I have researchers coming and saying it's just a really simple install. Well, unfortunately, GP practice systems are managed through the ICB and locked down. So the individual practices can't easily download and install any software. That all has to go through the IT department. And there are cybersecurity standards just come in this last month. So there's a link to that as well. So that brings me on to time frame. So these things all take time, and dealing with software and dealing with IT departments, as well as all these other things that we've already mentioned, these can all take time, and you must make sure to build in plenty of time into your planning and application, because they can take a long time. Data specification, we do try and make sure that you can really understand what data you want and really get to grips with what data you can get and what you need and where you're going to get it from. And all of this should be documented in a data handling policy. You would normally have a data sharing agreement or data processing agreement as well in place with any and all sites. And all of that should also include things like archiving, and also if there's ever going to be a secondary use of the data. So for example, giving the data to another research project, or passing things on, or using it for something different other than your original use, all needs to be part of your data handling policy. So you'll be glad to know that's the last of the pitfalls that I've found at the moment. and hopefully the last of the confusion and complications. So, but hopefully, I think really each data project has its own challenges, and sometimes you think, well, I'm doing something. Quite often researchers are trying to do something that's non-standard or different, or in some ways is doing something that's not been done before or wants to do it in a different way. So really, I would advise to get in touch as early as possible. We kind of have a coordinating role across the ICS, and we can signpost you to different organisations. And we're always happy to answer questions. They aren't always straightforward. We understand that. I can't say I can give you all the answers, but I could definitely look into any questions. So that's it.
Thank you so much, Rose. I think you might get quite a lot of emails. It's good to know that you and Stella are there. Has anyone got any questions for Rose at the moment? There was a question in the chat, Rose, about whether you're happy to share these slides with people, if I'll be able to send them around afterwards.
Yes, yeah.
Oh, that's great. So at the end of this, I'll send the recording round and also the slides and an evaluation form. We've got a raised hand from Jenny. Jenny, would you like to ask Rose a question?
Just a quick one. Just wondering, with this national opt-out, could you give us some idea about the percentage of people who do opt out?
Yes, I actually looked that up just before I came on because I was interested myself. It's just over 5% of patients currently have done an opt-out. So it's not nothing, but it's not huge.
I've just moved the slide so I can see everybody. I'll just have a look to see if anyone else has got any more questions. I've got a comment from Jason in the chat saying, thanks for showing the presentation. Really keen to explore the slides afterwards. So yep, that will get sent through. We've got a question from Hugh. If you'd like to go ahead.
Hi, thank you, Rose. That was really interesting. I'm currently doing a PhD in which we're developing software to extract data from GP practices. So what you said at the end was quite an important part for me. Do you have any suggestions in terms of developing the searches for EMIS Web and TPP System 1? We've been trying to approach EMIS and TPP directly, no luck. So we've been relying on the GP practices developing the searches themselves. Is there another way that you're aware of to develop a search?
Yeah, so there's a bit of an initiative, well, there is an initiative called PRIDES, PRIDES, and that's about using a standardized search. So they were finding that lots of researchers go into a practice and say, oh, they want to work with 50 practices, and they just go to the practices and say, can you find us X? So every practice is writing a separate search, and they're all slightly different, and actually we should be really consistent and only done once, and then it's consistent across the patch. So that's an initiative from the CRN, and CRN does have some resource to develop searches, so they're one aspect that you could look at. But working together with the GP practice is usually the thing I would advise, because they work with that system day in, day out. There is a way to then share searches and use the searches more widely so that you don't have to have everybody doing it separately. And then, like I say, it makes it more consistent. You can, yeah, my team's got quite a lot of experience on this, so we're happy to talk with you.
Oh, that'd be brilliant. Thank you very much. I'll email you, definitely. Thank you.
That's great. We've got a couple of questions in the chat, Rose. So we've got one just asking about how you can get access to the recording. So once the recording's on our YouTube channel by the end of this week, I will email it around everybody that signed up for this. So even if you joined late or didn't attend, that'll be coming through to your inbox. We've got a question from Claire that's asking, how far have most practices got in terms of including the new CRN research dissent code onto patient records, please?
Sorry, I didn't see that.
That's from Claire, if Claire's around.
Yes, I can't tell you the answer to that, to be honest. I think it's not something that I'm aware of particularly. I'll definitely take that back and see if I can find out, because I'm in touch with the CRN regularly. So
okay, I don't know whether anyone can see my camera or not, but we got a query recently from East of England CRN saying that our searches hadn't got the new CRN descent code in them, and that they are checking all the searches that they'll be running through their GP practices to see if the new code's been added. So that came through last week. So that's where that query's come from. If you need any more information about it, I can send you the website that they forwarded to us. And it's just, it relates back really to the national data opt-out. I think it's felt that the data opt-out is being used potentially not to quite reflect what people wanted it to reflect. So they've introduced this new descent code, and we don't know whether, even if we do incorporate it into our searches as the CRN are asking, I don't know whether practices have got that code on their systems yet. So I just wondered whether that is across the board, whether that's a national approach that all the CRNs wanting to have those descent codes included, and whether it would even work if we do.
That's really interesting. Yeah, I'll definitely look into that, because I think that's an interesting one. The opt-outs, yeah, I see what you mean, that it's maybe not capturing. The other thing with the opt-out, sometimes considered that it prevents you from being invited to a research project, which is not necessarily the case.
Yeah, no, I
You still be
appreciate that.
invited, which is not quite the same thing as your data being included without your consent.
Yeah, exactly. So I think there's maybe a bit of a concern that people practices have been using that code because that's the only code, the national data opt-out was the only code available to them to convey that, and of, like you say, it's not really for that purpose. So yeah, I can send you the website that we've got.
Thank you. Yeah, that would be really helpful. Thank you.
Thank you.
That's great. So we've got a question, Rose, from Yash in the chat. He's wanting to know a little bit more about implementation and current advantages of the SDEs that you might be aware of, and if there are NHS trusts who are currently already using the infrastructure. And I will just plug, we are going to have a SDE lunch and learn, everyone, coming up soon. So make sure you sign up to our newsletter for the alerts for that. But I'll pass over to Rose.
Yeah, so I think SDEs are really an emerging thing that have been implemented really in completely different at completely different levels across the systems. And so let me just see advantages of SDEs. I mean, it's just it should be much more straightforward. It means going somewhere that doesn't have to then, you should remove some of your requirements for liaising with individuals. You should be able to remove some of you should be able to see things that you wouldn't be able to see any other way. I can't tell you how well it's developing, because it's really in different ways across the system. And I think NHS England's one may end up being, I don't know if the NHS England one would be the main thing or whether the local ones would be the main thing. I think, yeah, it's gone a bit quiet on SDEs, but I'd like to see what the next lunch and learn has got to say about it.
Yeah, so that's just being organised at the moment, Rose.
I hope that you can hear me. So the reason why I asked that question was because I attended a workshop recently on somebody who was developing SDEs and specifically looking to partner with certain NHS local trusts for, going for funding opportunities as well as implementing the SDEs. So we was easy within the NHS as well. And the fact that SDEs allow a lot of anonymity and decentralization, but at the same time might not allow you to do reverse searches, for example, which is not necessarily needed, but is sometimes important in regards to the governance of things. So just want to know a little more about that, and if you know that there are certain advantages, and if there are any NHS trusts that maybe are already using SDEs and have found that, all right, this is working for them, so that we can also contact them.
Yeah, I think just generally contact the individual trusts or I don't know who is delivering the lunch and learn, Kate?
I'm not sure who's doing it at the moment, but Yash, I can put you in touch with the comms officer for the Yorkshire and Humber SDE, who will be able to pass on your query to that team, if that's okay.
Yeah, that'll be great. Thank you so much.
That's lovely. I'll do that now. And Asim's got your hand up if you want to go next.
Hi Rose, thank you very much for the like the summary of the almost some or all the issues that I'm facing in the past 4 or 5 years, because we are collecting data from around 10 sites in Yorkshire and Humber, and we are having similar problems, either regarding the administrative part and the approvals part, security part, or that regarding the linking between different sites, which is the challenge now, because every hospice or hospital or community service have their own system, so they are working independently. So my question would be, like, do you have an idea? Like you talked about different sites and how to link between different assets. The only way that we started to look into it was try to do what is called pseudonymize the assets, where you apply a macro in Excel, where you put the NHS number, and it will give like a 24 characters that you cannot reverse engineer into the NHS number. This so far what we like tried to do, and later we try to pull all of the assets in one thing. So do you have a different approach in linking different assets from different sites? Consider sometimes the sites will only accept if they give you the data anonymized. So they will give you like IDs that is not related at any means to the previous. Yeah.
Yeah, so the SDEs should be a way of doing that, and using some of the external things that I've mentioned, like the HDR UK data sets. There are ways that pull things together, and pulling together yourself using an identifier yourself. Again, like you said, it's just a case of convincing the individual organisations that you've got sufficient safeguards in place, and make sure you're working appropriately. If they only agree to provide you with anonymized data, you don't have any way of linking. You can't link that in because there's just no identifier to do the linkage. So yeah, working together with working on the 5 SAFEs framework, working on secure data environments, connected cities brings some things together. But yeah, if they won't give you anything other than anonymized data, I don't know what else to suggest, really. Unfortunately.
Thank you.
Thank you, Asim. Has anyone else got any more questions? This is your last warning. But we'll let everybody go. No, I think that's everything. So yeah, look out for the email that'll be coming through with the evaluation, the slides, and the recording link. Should hopefully be towards the end of the week. Thank you so much, Rose, for giving us this presentation today. And then, like I said, we'll be trying to get someone from the SDE to come and do a lunch and learn on the SDE. There's plenty on our website at the moment. Our next one is about the way that NIHR have an in-house Wikipedian who uses NIHR to disseminate research from the NIHR. So it's really, really interesting. I've seen that presentation before, and that's on the ARC website. So they're all on there to sign up too. So thank you very much, everybody. Go and enjoy the rest of your lunch.